All right, this will be a two-part lecture on movement disorders. And so we'll be starting here, kind of breaking movement disorders down into two big categories, hypokinetic and hyperkinetic. So as the name indicates, hypokinetic describes a slowing of movement, really a poverty of movement. Bradykinesia is a term we'll refer to several times in this lecture. And then in the next lecture, we'll talk about hyperkinetic movement disorders where we have excessive involuntary movements. And we'll cover the treatment, mainly the pharmacology, for both of those categories in those lectures. All right, so just a couple well-known individuals here with Parkinson's disease, relatively common condition, so quite a few well-known individuals who have developed this condition. So first, let's just review a little bit of the neuroanatomy of the basal ganglia. And so let's just talk about this area right here around the internal capsule. So remember, our internal capsule has an anterior limb, a genu, and a posterior limb. And so we've talked about how the cortical spinal tract travels in the posterior limb. The cortical bulbar tract is at the genu. And we've been over all the different pathways located in the internal capsule. But it's such a helpful separation here between the caudate, which is medial to the anterior limb, the thalamus, which is medial to the posterior limb, and then lateral to that we have the putamen and globus pallidus. And over here we can just see the putamen. On this side we can see just a little bit there of the globus pallidus. So remember, these are together referred to as the lentiform nuclei because they have a lens shape. Whereas, more important, functionally, we have the caudate and the putamen, which work closely together functionally, and these are referred to as the striatum. Okay, if we want to see other components of the basal ganglia, we can do a coronal cut here. So now we're looking at the posterior limb of the internal capsule, and we know it's the posterior limb because we can follow it right through the midbrain here. So this is the cerebral peduncle. So this is that cortical spinal tract as it's traveling all the way down through the midbrain and the pons. And so in that area, kind of right at that junction between the posterior limb becoming the cerebral peduncle, we can see this football-shaped nucleus here, right? So that's the subthalamic nucleus. And then just a little bit lower, medial to that, we have the substantia nigra. Okay, because of the pigmented neurons here, this usually stands out. Lateral to that, we can see the lentiform nuclei. So here we can see nicely the putamen and the globus pallidus, which has an external and an internal segment. All right, so problems with the basal ganglia, whether it's the putamen or globus pallidus or subthalamic nucleus, or the substantia nigra, or the caudate, which is up here, results in movement disorders, but it's worthwhile saying what most of these patients do not have. They do not have, in general, upper motor neuron findings. So here's the upper motor neuron pathway here, one of them, the cortical spinal tract. And they're not weak. Now, they have a hard time moving, but it's not really due to weakness. So they don't have upper or lower motor neuron findings. They have abnormal movements and, in general, difficulty moving. So remember that the basal ganglia structures here, the caudate and the putamen, well, the caudate anyway is a C-shaped structure, kind of parallels the lateral ventricles. All right, and so remember the caudate and the putamen function closely together, so they're referred to as the striatum. And here we can see the substantia nigra, which is way down here in the midbrain, has these projections up to the caudate and putamen called the nigrostriatal projections, or neurons. All right, so first let's just categorize some different movements. Hyperkinetic movements, which we'll say more about next time, are a lot different. So these are excessive involuntary movements. Bellismus refers to very large amplitude, sort of flailing, chaotic movements. We've already talked about hemibolismus as kind of our classic condition here, where one side of the body is just dramatically moving, flinging around. Choreiform, chorea in Greek means dance, so these are kind of quick, random movements that are, again, tend to be fairly quick. Athetosis is sometimes referred to as a slow chorea, so it has more of a writhing quality as opposed to chorea, which is more quick and jerky. Tics, we'll only talk about Tourette's syndrome in the next lecture, but these are intermittent movements that for each individual tend to be quite stereotypic. So it may be the head jerking in a specific direction, and patients do that over and over again. Or patients may just fling up their right arm, and that tends to be their tic. Tic disorders like Tourette's often go along with vocalizations, throat clearing, nose sniffing, things like that. Dystonia is a sustained muscle contraction, and so we'll talk about cervical dystonia, where patients have these twisting movements of the neck where it just gets pulled in one direction. It's very tight in that direction. And patients involuntarily will fight the dystonia, and that often results in what's called a dystonic tremor. So the head shakes, but the shaking is the patient trying to overcome the twisting movements. So these are all in a hyperkinetic movement disorder category, and I just put them here to kind of contrast with what we're going to talk about in this lecture. So the hallmark of a hypokinetic movement disorder is bradykinesia, which is a poverty of movement. Everything slows down for these patients. They walk slower, getting out, in and out of a chair is more difficult, rolling over in bed. They just can't do things, quick and effortlessly. And oftentimes the spouse is the one that will point that out. They always go for walks, and now he's just kind of seems to be dragging his feet. So a quick review of the anatomy in terms of the neurotransmitters that are involved from the first year. And again, as I told you last year, the payoff is that this is actually helpful. It's a very simplistic model, but it is helpful for understanding why patients either develop into a hypokinetic or a hyperkinetic movement disorder. So recall that the motor cortex here, when it talks to the basal ganglia, it talks to the striatum. Okay, and so we have all of this kind of going on here with connections with the striatum, but notice that when the basal ganglia here needs to talk back to the cortex, I told you last year that it's the internal segment of the globus pallidus that does that. Well, really, there is another part, the pars reticulata of the substantia nigra, is part of this output nucleus as well. These are not the dopamine-producing cells in the substantia nigra. Okay, and so these project back to the motor cortex. Remember, anything that goes to the motor cortex, virtually anything except for olfaction, has to go through a nucleus of the thalamus. And so in the case of the basal ganglia, it's the ventral anterior nucleus of the thalamus. Okay, here in the basal ganglia circuitry, we have what's called a direct route, which goes out from these D1 dopamine receptors to the output nuclei, GPI and pars reticulata of the substantia nigra. And then we have the indirect route, which goes through a D2 dopamine receptor, and it has two extra steps. It goes through the external segment of the globus pallidus and through the subthalamic nucleus. Okay, but the payoff for this is we have to plug in the neurotransmitters. And so how I remember this is that anything that relates to the cortex here, whether it's going out or coming in, is glutamate. Glutamate is stimulatory, excitatory neurotransmitter, so we put 2 positive marks. Everything else is GABA, or inhibitory, okay, with the exception of the connection between the subthalamic nucleus and the output nuclei, which is glutamate. Okay, so it'd be worthwhile practicing a little bit to draw this out, on a blank sheet of paper. And the one other, of course, important thing we need to understand is that in the pars compacta of the substantia nigra, so usually when we say substantia nigra, we mean the pars compacta of the substantia nigra. This is what projects dopamine up to the striatum. And so notice the unique effects here that dopamine stimulates the D1 receptors, whereas it inhibits the D2 receptors. Okay, so that is the normal basal ganglia circuitry. And now let's understand what happens in Parkinson's disease. So in Parkinson's disease, we have a degeneration of the pars compacta, so less dopamine is projected to the striatum. And the basic idea of this model is that whatever is happening here in the basal ganglia, if the net result is less glutamate going back to the motor cortex, then we have a hypokinetic movement disorder, and the patient slows down. They look like they have Parkinson's disease. Okay? If the net result of what's going on here is more dopamine going back to the motor cortex, then we have a hyperkinetic movement disorder. So what happens in Parkinson's? Well, we have less dopamine going to the striatum, so we stimulate the D1 receptors less. Okay, if we stimulate the D1 receptor less, it's going to crank out less GABA. GABA is inhibitory, so we had 2 here before, now we have only 1. It's going to inhibit the output nuclei less, and if you inhibit them less, they're going to put out more GABA to the ventral anterior nucleus of the thalamus. It's going to shut down the thalamus, and we have less glutamate going back to the motor cortex. Okay, we can see that what's going on through the indirect route just amplifies that whole situation. So now, less dopamine, so we have less inhibition on D2. Less inhibition means more GABA is going to be put out to inhibit the external segment of the globus pallidus. If we inhibit this more, it's going to put out less GABA to the subthalamic nucleus. So if we inhibit this less, it's going to put out more glutamate to further stimulate the output nuclei, to put out more GABA to inhibit the thalamus, and we shut down glutamate going back to the cortex even more. Okay, so that's kind of the basic idea, and as we'll see, this is also helpful to determine when we do deep brain stimulation. Where do we want to stimulate here in the circuitry? Which is a little bit, deep brain stimulation, as we'll see, you really end up inhibiting the areas of the brain where you do the stimulation, but we'll explain that here in just a little bit. All right, so just a couple of terms. So hypokinetic movement disorder, we can think of these as Parkinson's disease and Parkinsonism. And these terms are often not used precisely, but when a neurologist uses the term Parkinsonism, generally that means, yeah, you know, there are some features of Parkinson's disease, but it's really something else. It's making the patient look like they have Parkinson's disease, but it's really something else. So for example, if you give medications that block dopamine, that patient can look a lot like they have Parkinson's disease. They don't. They just are on that medication that's blocking dopamine. So we would use the term Parkinsonism, a drug-induced Parkinsonism, to describe that. And we'll see there are some specific diseases, neurodegenerative diseases, that can sometimes be difficult to distinguish from just typical Parkinson's disease itself. All right, so here is the original essay on the shaking palsy by James Parkinson in 1817. And so we can see overall incidence is about 19 per 100,000. 1 to 2% of all individuals over the age of 65. So in terms of the clinical features, TRAP is a helpful way to categorize the different features clinically of Parkinson's disease. The T is tremor, and this is the single most specific feature that suggests the patient has Parkinson's disease. So what makes it specific is that it is a rest tremor. Okay, there are very few other things that are predominantly a rest tremor. If you have just a really bad tremor from any other cause, you may also shake a little bit at rest. But in Parkinson's disease, it's predominantly a rest tremor that often gets better when the patient moves their hands. Movement will have the effect of reducing the tremor a little bit. We sometimes call it a pill rolling tremor. In our session next week, I'll show you a number of videos of patients who have Parkinson's disease. It is the initial symptom in more than half of patients. So that's usually the first thing that the patient or the spouse will notice. But important here just to realize that although this is kind of an obvious thing that leads to the diagnosis, this is really not the disabling feature. Okay, the disabling features are in the akinesia or bradykinesia category for the most part. So the R is rigidity. I've not very often had patients come in and say, I feel like my arm or leg is rigid. This is more of an exam finding. But we do get increase in muscle tone in Parkinson's disease. Remember, there are a couple of different things that can give you increased tone. Well, several things really, but for now, let's just contrast here rigidity and spasticity. So spasticity is seen when we have an upper motor neuron lesion, and that is velocity dependent. So remember, if you move a spastic arm or leg quickly, there's a catch. That's called clasp knife spasticity. Rigidity is not velocity dependent. So if you have someone with Parkinson's disease, spend some time checking the tone at the wrist and the elbow and in the leg. And what you'll find is that the rigidity is fairly constant, no matter how fast or how slow you move the limb. And of course, spasticity is going to be associated with hyperreflexia, Clonus, Babinski sign, and other upper motor neuron findings. So rigidity usually overlaps with cogwheeling, and we use the term cogwheeling rigidity frequently. And what this describes is you have a patient with a rest tremor, and you're asking the patient to relax. You're feeling the tone in that arm, and you'll feel the rigidity, but you will also feel the tremor at the same time. So that's what creates that kind of a cogwheel effect. It's stiff, but you can also perceive the tremor simultaneously. The A is akinesia, really bradykinesia is a better term, and so this is where the disability lies for these patients. And every single thing here I have on this slide is seen in almost all patients that have Parkinson's disease. You know how sometimes you get a list of symptoms and maybe 20% have this, 10% have that. If you go through these symptoms with patients that have had Parkinson's for, more than several months, or certainly more than a year or so, most patients will have all of them. All right, so everything slows down. The swallowing frequency slows down. So we don't need to remember to swallow a certain number of times every minute, but you can imagine what's going to happen if your swallowing frequency goes down. Saliva builds up, and therefore drooling is a common complaint of Parkinson's disease. Patients don't blink as much, and so they have a facial expression that can appear less animated. They can appear a little bit more like they're staring. Okay, and just facial movements in general are reduced. So they can have kind of what's called a masked face appearance. Any fine motor task is difficult in patients that have Parkinson's disease. And so handwriting typically becomes very small. It can be very difficult to write. And oftentimes the first few letters may start out big, but then they trail off and get really small. Using tools like a screwdriver can be difficult, teeth brushing. I always ask patients about doing buttons on a shirt, and that is almost always difficult for patients to do, especially like the cuff on the opposite wrist area can be a challenge. So a useful test for patients with Parkinson's is to ask them to tap their fingers. And so I'll ask them to tap their thumb and index finger big and fast. And oftentimes they'll start out big and fast, but then it gets really small. Okay, so that kind of is a good way to assess for fine motor tasks. Now, I actually should have mentioned or emphasized when we mentioned the tremor, that the symptoms in Parkinson's disease are almost always very asymmetrical, right? So one arm is shaking, and then over time the other arm may shake, but it's always going to be one side of the body that is predominantly involved. And so that's true with the tremor, and it's also true with difficulty with fine motor tasks. So it's unfortunate if the more affected side just happens to be the the dominant hand. So if someone's right-handed and they get the tremor and rigidity and bradykinesia in the right arm, then that's just going to make life a little more difficult for them, certainly with typing and handwriting, things like that. The voice becomes soft, often kind of low, a little bit hoarse. That's called hypophonia. So the spouse will often complain of that and say, they keep asking her to speak up, but the voice is really soft. Rolling over in bed, just the inertia to do that is more challenging with Parkinson's disease. And these patients always have great difficulty getting in and out of chairs, or especially a deep sofa. People need to pull them out, or getting out of the back seat of a car. All of those things are difficult. And if you just observe someone with Parkinson's walk, they don't take long step stride. They tend to take more shorter, kind of shuffled step size. So all of these would fit in the category of akinesia or bradykinesia. The P is postural instability, and so this is really a later feature in Parkinson's, which is really important. If you're talking with someone and you're thinking, okay, this is kind of sounding like Parkinson's disease, but the first symptom was falling, you better rethink that. It's probably something else. So this happens later, after the tremor and after all the bradykinesia categories. And oftentimes what will happen in Parkinson's is that patients will have freezing, where they're walking along and all of a sudden their feet will just lock up and get stuck to the ground. Interestingly, this often happens when things close in a little bit, such as walking through a doorway. Okay, we can do what's called a pull test, which I will show you in class next week, where you come behind a patient with Parkinson's and you grab them on their shoulders and you just give them a tug backwards. And of course, you're going to reassure them, I won't let you fall, and usually I have a medical student or two with me to, make sure that they don't fall. But oftentimes what will happen is patients will start taking steps backwards and they can't stop, and then you have to physically stop them. So pull tests can be helpful. Patients have, as I said, a shuffled gait. Usually the body, from the waist up, kind of flexes forward, so that can make them unsteady because you've got the weight of the body now sometimes getting in front of the feet, so they can just kind of topple over. And observe the arm swing in patients that have Parkinson's disease. So the arm that is more affected will not swing as well. And so if the patient has a rest tremor in the right arm when they walk, that right arm is not going to swing to the same degree as the left arm. And oftentimes you'll see the rest tremor come out as someone is walking. Okay? Now, Parkinson's disease has a lot of other things that go along with it. Depression and anxiety incidence is increased. And again, like I said with multiple sclerosis, this is not just patients are sad they have the condition, but it's an organic part of the neurodegenerative process. You can see dementia is around 20 to 30%. That's a later feature. All right, dyskinesias are really important, which I'll explain in just a minute here, but I put this in asterisks because patients only get dyskinesias when you put them on dopamine medications. So this is a classic feature of Parkinson's disease, but it's really a side effect of medications, and patients will not have dyskinesias until you treat them. Constipation, I think more than 90% of patients with Parkinson's disease have constipation, so this is a really significant issue. Oftentimes patients will have sensory symptoms as well. The term numbness, as I mentioned last year, is a very vague term, but sometimes it's described as like an achy pain, again more often in the affected side of the body. Sweating is common in patients with Parkinson's disease, especially if they're undertreated, then they may have more sweating. Seborrheic dermatitis, I have a picture here, is kind of this scaly erythematous region that tends to be more prominent in the forehead. And some patients with Parkinson's may have dystonia. Remember, that's a sustained muscle contraction. And so the one I've probably seen most often is that when patients walk, their foot will just kind of twist and turn in, inverted in. So that would be a dystonia. Hyposmia, or loss of smell, is seen in 90% or more of individuals. And this may tie in with just loss of appetite, and sometimes as Parkinson's advances, weight loss is very common. There are some other factors there, but just loss of smell and therefore loss of taste is part of what's at play there. Now we will see that Parkinson's disease and two other conditions are highly associated with REM sleep behavior disorder. It's seen in maybe only 60% of patients with Parkinson's, but when we go over the sleep disorder lecture, I'll explain this in more detail, but during REM sleep, there's paralysis of muscles throughout your body, except for breathing and eye movements. And that's a good thing, because REM sleep is when most vivid dreams occur, and so this prevents us from acting out our dreams and hitting, our spouse or whatever. And so REM sleep behavior disorder, these individuals lose that muscle paralysis, and so they can be quite violent during sleep. Especially, I work at the VA, and veterans frequently have PTSD. They're remembering things from their military service. And, I've had a number of vets where their spouse needs to sleep in another room because they're just thrashing around violently at nighttime. So I ask about that in any new patient that I see with Parkinson's disease. And we will see that there are two other conditions associated with that, even more highly than Parkinson's, conditions we'll talk about later: diffuse Lewy body disease and MSA, or multisystem atrophy. So if you're seeing someone who sort of looks like they have Parkinson's disease, look for these as kind of red flag symptoms that should suggest to you an alternative diagnosis. If they have early dementia, okay, maybe at onset with the tremor, they also have dementia, that should suggest something else. I'll tell you later what that something else is. If they have early autonomic symptoms, so they stand up and they're passing out all the time, they probably don't have Parkinson's disease. Again, early falling is a red flag symptom. Early hallucinations. Okay, and if they have specific, unique findings on exam, especially with relationship to eye movements and ataxia, that would suggest an alternative diagnosis. And almost all patients with Parkinson's disease early on respond very well to dopaminergic therapy. So a lack of response should suggest that you're not dealing with Parkinson's disease. All right, so again, the videos here we will show together in class next week. So in terms of the pathophysiology, here we can see on the right a normal midbrain, a pretty healthy substantia nigra, and by comparison here, this is what it might look like in someone with Parkinson's disease. All right, so we have a loss of the dopamine neurons here in the pars compacta of the substantia nigra, and Dr. Deich will show you Lewy bodies here, which we look for in the substantia nigra. All right, so here's the midbrain. And last year in the neurotransmitter lecture, I talked about dopamine projections from the midbrain. So we kind of have emphasized here the nigrostriatal tract, but we also have a mesocortical tract. Remember, the midbrain embryologically is the mesencephalon. So that's why this is called the mesocortical tract. And loss of dopamine projections up to the cortex have to do with some of the motor manifestations of Parkinson's and probably some cognitive aspects as well. And I really wanted to show this here to remind you that there's also dopamine projections up to the limbic system, and most importantly for our lecture, the nucleus accumbens. And so as we try to understand some side effects of giving dopamine agonists, we'll see that this nucleus accumbens accounts for some of the kind of unique addictive impulse control disorder that can occur as a side effect with these medications. All right, it's overly simplistic to say that Parkinson's is just a result of a loss of dopamine, because actually we have other areas of the brain that degenerate as well. The dorsal motor nucleus of the vagus degenerates quite early in Parkinson's. Now remember, that's parasympathetic output to your GI tract. So why is constipation so common in Parkinson's disease? There's some different anatomy that's involved in that. The locus coeruleus I'll say more about later, but the olfactory bulb is also involved in Parkinson's disease. And so that's why a loss of smell is quite common in addition. Now, I just find this fascinating that you need to have lost between 50 and 70% of your substantia nigra before developing any symptoms. And so this actually means that patients that finally develop that rest tremor and have Parkinson's have had this process going on, it's estimated, between 8 to 12 years prior to developing symptoms. Okay, so this is really going on for a long time. You have to have lost quite a few of these cells before symptoms come out. And so, again, I'm not a neuropathologist, but Dr. Deich will show you here the neuromelanin pigment, and there is a Lewy body. All right, so what is a Lewy body? Well, in 1997, they found mutations in the alpha-synuclein gene. So the abnormal protein, and that's really where the whole direction of neurodegenerative disorders is going, is the abnormal protein and the gene that's associated with that. And so Parkinson's disease is classified as a synucleinopathy, okay, because we have abnormal alpha-synuclein. And so this protein is normally present at presynaptic terminals. And so if we have a mutation in the alpha-synuclein gene, and there are many different mutations, you get these aggregates, and these are the Lewy bodies. And so we will see that there are 3 different conditions under the umbrella term synucleinopathy. Parkinson's, certainly most common. Dementia with Lewy bodies, a very important condition. This is what Robin Williams had. We're going to discuss that in the dementia lecture. Okay, but they have features that overlap with Parkinson's disease. And then multisystem atrophy, which we will cover in this lecture, is a synucleinopathy. Okay, and just to give you an example, that REM sleep behavior disorder condition I just talked about is very common in all 3 of these conditions. Okay, so that's a classic feature of a synucleinopathy. So there have been many of these so-called PARC gene locations, and so if someone does have a hereditary cause of Parkinson's, it tends to be in your younger patients. So someone maybe under the age of 50 that develops Parkinson's disease would more likely have a genetic contribution. We know that there are environmental factors and endogenous factors, but there isn't like a clear, 1 or 2 things here that I can share with you in terms of risk factors there. So in terms of diagnosis, we need to have things fit all of the TRAP. So clinically, that is consistent. And again, patients respond well to therapy. And then, we can confidently say this is Parkinson's disease, and we don't have red flag symptoms. So we can't send the patient to the lab for a blood test to see whether or not they have Parkinson's disease. There is a test that can be done. We don't do it very often, but it's a SPECT scan where the patient is injected with something that tags the dopamine transporter. Okay, right here. Here's dopamine in synaptic vesicles being released. And so by tagging the dopamine transporter, this basically tells us about how dense the dopaminergic neurons are. And so when we do a DAT scan, and I wouldn't show you pictures of this, but just to give you an idea, this is kind of a normal striatum appearance. It looks like a comma, all right? And in a patient with Parkinson's disease, we can see it looks more like a period, and it's asymmetrical here. It's smaller here on the left side. And so why would we do a DAT scan? Frequently, it's like, let's say we have someone who we think might be malingering, who's coming in with a tremor, but things are just not fitting. Well, this would be kind of an objective test then, that we can sort of see, well, actually, you've got a normal, functional dopaminergic neurons. DAT scans do not distinguish between Parkinson's disease and all of the things that I'll explain just a minute in the Parkinsonism category. Okay, it just tells you your patient either has Parkinson's disease or Parkinsonism, but it doesn't sort out which of those conditions that you're dealing with. All right, so let's go over treatment now of Parkinson's disease. If someone is under the age of 65 and is having symptoms that are progressive to the point it's really interfering with their activities of daily living, it's interfering with their livelihood, most neurologists would still start with a dopamine agonist. Okay, and there's some debate about that, but in general, younger individuals will tend to start with a dopamine agonist. I'll say a little bit why here in just a minute. So of the oral dopamine agonists, you have bromocriptine, pramipexole, and ropinirole. Bromocriptine is really not used in the treatment of Parkinson's disease. So pramipexole and ropinirole are definitely the two that you should know here. Bromocriptine is otherwise known as prolactin inhibitory factor, and we will talk about that and its utility in terms of treatment for another condition later on. So dopamine agonists are our most effective medications next to levodopa. Levodopa is the strongest, most effective medication, but dopamine agonists really work quite well. They do have a longer half-life than just giving levodopa, and so we can give this like 3 times a day, and it can be helpful in just kind of smoothing out how the patient is doing so that they're not, going up and down throughout the day. Those are called motor fluctuations. That's common in Parkinson's. So these are mainly agonists at D2 and D3 dopamine receptors. They don't do much at the D1 receptor. But again, they're very effective, but they have a number of side effects. And really you should know everything on this slide because these side effects are fairly common. The first 2 are the most common of any dopaminergic medication. Okay, so you can just kind of plug that in whether we're giving a dopamine agonist or dopamine. So nausea and hallucinations. These are the 2 that I'll really spend time discussing with patients when I start these medications. Nausea can be reduced a little bit by taking the medication with food. And when you stimulate dopamine pathways, again, think of that striatal limbic, the nigro-limbic connections there. It tends to stimulate false visual sensations. That may be nothing more than a shadow on the wall, but it can be real people that are standing there and animals. And I had a patient not too long ago who kept seeing a fish with teeth that would come out of the bed. So sometimes these can be rather troubling. All right, so just to be aware of that, and if your patient is getting a lot of hallucinations, then you're probably pushing the medication too much. Now, confusion can happen but mainly that's when we use it over the age of 65. And so that's why if I have someone over 65, a dopamine agonist is generally not my first choice, because these patients are already susceptible to having some dementia, some cognitive deficits, and so I would prefer to use a dopamine agonist in younger individuals. All right, now the next one here is unique for dopamine agonists. Very important you're aware of this. It's surprisingly common. And so all of these different symptoms here fit under the big category of impulse control disorder. So gambling is quite common. When I put someone on a dopamine agonist, I usually ask them, if they gamble. And if they do, then hopefully there's a family member there who can hold them accountable that these patients should not be going to Las Vegas and should not be, betting money, because the dopamine agonist will sort of stimulate that behavior. So kind of related to that, I've seen a number of individuals on a dopamine agonist who got addicted to video games, surprisingly even older individuals who'd never played video games before but now are just kind of wrapped up in them. This can be an addiction to pornography, sort of a compulsive eating disorder, and sometimes a sexual dysfunction can occur. So really helpful to have the spouse there when you're seeing the patient back, just to kind of explore, are there any changes that have occurred in this area. All right, so I think in one day, I had a medical student with me a few months ago, and we saw this twice in two different patients in one day. And so, frequently it's not a big deal, but if someone is spending a lot of money, they can't control themselves, then you really just have to back off on this medication. So vivid dreams, kind of tying in a little bit with hallucinations, can occur. Sudden attacks of sleep. This is unique for dopamine agonists. I haven't seen this very often. This is not like most medications, that just will make you drowsy. But rather, dopamine agonists can cause patients to go from just being wide awake to suddenly asleep. And so if I have a patient that has even one attack of this, well, they can't drive until they get, off of the medication. So you take that symptom quite seriously. Especially in a more advanced case of Parkinson's disease, a dopamine agonist can promote hypotension. So patients, if they stand up too quickly, feel very dizzy, lightheaded, might pass out. And dyskinesias, which can occur with any dopamine therapy, including dopamine agonists. And so what happens here is, let's just imagine, someone is not producing as much dopamine. And so the dopamine receptors then upregulate. So then when you give a medication that stimulates dopamine receptors, you can now overstimulate dopamine pathways. So the patient goes from not being able to move to now having extra movements. Okay, and if you want to see what dyskinesias look like before next week, you can just see some videos of Michael J. Fox at interviews. And you may say, well, it doesn't look like he has Parkinson's disease. He's kind of twisting and writhing and moving around. Well, those are dyskinesias, and that means that he just took his dopamine medication. It's a side effect of the medication. So years ago, he went before Congress to testify, and he was just dyskinetic, moving all over the place. And Rush Limbaugh went on the air and said he stopped taking his medications to get sympathy. And I remember all the neurologists were shaking their heads because, well, no, he just took his dopamine medication. Anyway. Now, rotigotine is a dopamine agonist that is a patch. And so this can be a nice option. Patients just put a patch on, and it delivers a nice steady delivery of the medication. All right, so we have dopamine receptors. So we can either directly stimulate the receptor via a dopamine agonist, or we can give the neurotransmitter itself dopamine. But we can't just give dopamine alone. Okay, if you read back many decades ago when they first started giving patients dopamine, they all became violently ill and were throwing up. So we have to give the precursor to dopamine, which is levodopa. And we always have to give this with carbidopa. Why do we give carbidopa? Well, when I show you the enzymatic breakdown here, this will make just a little more sense. But levodopa is converted to dopamine by dopamine decarboxylase. And the carbidopa inhibits the dopamine decarboxylase peripherally. Okay, and so if we didn't give it carbidopa with it, the levodopa would immediately get broken down into dopamine, and the dopamine then would stimulate areas in the brain that lack a blood-brain barrier and would cause intense nausea and vomiting. So the carbidopa allows the levodopa to cross the blood-brain barrier, get into the striatum, and there it gets converted into dopamine, and it does all of its positive things to help the patient move again. Okay? And so there are different formulations of carbidopa, levodopa, and obviously I'm not going to ask you to memorize 10, 100, 25, 100 and all of that, but the first number, the 10, the 25, that's carbidopa. The other number, the 100 or the 250, is levodopa. And so it turns out that most patients need at least 75 milligrams of carbidopa to prevent nausea. And so what I will sometimes see is, maybe someone not experienced treating Parkinson's disease, but they've got a patient before them who clearly has it, and they'll start them on the 10-100s, thinking, well, I'll go with the lowest strength pill. Well, that patient is actually much more likely to get nauseated and have side effects, and so we will usually prescribe the 25/100 carbidopa, levodopa. And they can take that 3 times a day. That would be kind of a good starting dose, and that's enough carbidopa to prevent nausea. If someone does get very nauseated starting this medication, you just need to give them more carbidopa. Okay, that's usually quite effective. Okay, there's a sustained release form or controlled release CR form. And so what often happens as someone advances in their Parkinson's is that they take the carbidopa, it helps, they're moving, they're on, but it doesn't last very long, and then it wears off, and then they need to take it again. So having a long-acting form can help smooth things out a little bit. And a really good development here a few years ago is a so-called extended release form, which is known as Rytari. It's carbidopa, levodopa, but in that capsule are little beads of carbidopa, levodopa that are all released at different times. Some are released immediately, then others later, and then some much later. And so that's really been helpful for a number of my patients in kind of leveling off their function. They don't fluctuate so much. So I just wanted to remind you here of these areas in the central nervous system that lack a blood-brain barrier. So the area postrema would be the most important. This is the so-called vomiting center. All right, so if we didn't give carbidopa, then that levodopa is just going to get converted to dopamine, and it's going to stimulate the area postrema, and the patient will vomit. So levodopa is our most effective medication, and again, it would be very concerning if you think someone has Parkinson's disease and they're having no response to levodopa. Okay, because more than 90% of patients have a great initial response. And early on, it's what's called a big therapeutic window. Okay, so you're popular with your patients with Parkinson's early on. They come back, they're moving better, they're shaking less, they're happy with how they're doing. Becomes much more challenging when we're 5 years out, 7 years out from the initial symptom. Then it can become much more difficult to effectively manage things. So again, with time, patients have motor fluctuations, so the medication wears off, and that's the wearing off effect, or they're off, they're frozen, they're not moving well. Then they take their dopamine medication, now they're back on again, they're moving well. And oftentimes taking the medications then can overstimulate dopamine receptors, and they'll have dyskinesias. Okay, and so patients with Parkinson's can fluctuate greatly, and so when you're seeing someone in the office, maybe they're looking good, but they're describing things that sound like they're not doing well. Well, you may just be seeing them at a good moment in time. So side effects of carbidopa, levodopa. Just like with dopamine agonists, nausea and hallucination are most common. Okay, but notice carbidopa-levodopa does not cause the impulse control disorder or the sleep attacks that are seen with the dopamine agonists. So they don't have those same side effect profile. It can also cause vivid dreams. Again, that often goes along with hallucinations. Can also cause hypotension, especially in a more advanced case. Can also cause dyskinesias. Dyskinesias tend to be a little more prominent with levodopa therapy than with dopamine agonists. And it can contribute a little bit to confusion, but that is more of an issue with dopamine agonists. So again, that's a big reason why over the age of 65, we just prefer to start that patient on carbidopa-levodopa. All right, so those are our two kind of big gun medications for Parkinson's disease. There are some others that are used. So the MAO-B inhibitor used today is rasagiline. All right, it's usually well tolerated, so it does break down, slow the breakdown of dopamine in the striatum. You can't use it with other MAO-B inhibitors, and we'll actually cover that and talk about serotonin syndrome in our next lecture. The hope initially is that this might have some neuroprotective effect, but that has really been disproven. So as of today, there isn't a proven medication you can give a patient that will slow down the progression of Parkinson's. All the medications we have are symptomatic therapy. They help on the days when the patients take their medication. All right, so here is dopamine here in synaptic vesicles being released. So it gets taken back up in the dopamine transporter. Okay, so again, we can assess that using the DAT scan. We see a lot of dopamine being uptake here. That suggests a healthy dopaminergic system. And here is the MAO-B, which does break down dopamine. And so selegiline was the older form of this. Now rasagiline inhibits the MAO-B inhibitor, so we have less breakdown of dopamine, more dopamine availability. Okay, amantadine is an antiviral agent that probably acts both to stimulate release and block the reuptake of dopamine. For most patients, this is kind of a mild benefit. It's not the big game changer like a dopamine agonist or levodopa. And actually, its biggest use now is in patients that have dyskinesias from dopamine agonists or levodopa therapy. And this is really counterintuitive. How could giving a medication that would stimulate release or block reuptake help with dyskinesias? But it does. And so when we have someone with dyskinesias and we feel like we really can't back off on the levodopa or the dopamine agonists, then giving amantadine can sometimes help those patients reduce dyskinesias. Anticholinergic medications. I didn't show this in our diagram of basal ganglia circuitry, but within the striatum, the interneurons there use acetylcholine. Okay, and so if you block those, so these are muscarinic receptors there for acetylcholine, this can have an effect almost exclusively for tremor. So it really does not help for the bradykinesia symptoms or all of the other things that go along with Parkinson's. But if you have a patient with a really bad tremor, then that might be a time to try an anticholinergic. So the two that are used are trihexyphenidyl and benztropine. Right now, the other reason we really don't like to use anticholinergics is from our lecture last year on the autonomic nervous system. If you block muscarinic receptors, then you tend to get a whole bunch of side effects. I mean, these are in the brain, important for cognition, so it'll frequently cause confusion or memory loss. The acetylcholine receptors for the parasympathetic system that stimulate the GI tract. If you block those, you cause constipation in a patient population that is already constipated. So urinary retention. So these are all things that you don't want to worsen in your patient with Parkinson's. So that's why I would say I rarely use anticholinergics because of you're accentuating problems that the patient already has. Okay, so remember with the catecholamines here, we start with tyrosine to levodopa, and here is the dopa decarboxylase. So this is what your carbidopa is inhibiting. This allows the levodopa to get to the brain, and then in the striatum it gets converted by dopamine decarboxylase to dopamine. Okay, and so you can see the rest of the cascade here, but I just kind of want to emphasize that aspect of it. And so we have MAO inhibitors here, which break down dopamine, and also we'll talk about COMT as well. So the COMT inhibitor is entacapone, right? And so like MAOB, it has an effect on reducing the breakdown of dopamine, and there's really only one indication for giving a COMT inhibitor, and that is patients that are having early wearing off with the levodopa. So they take the carbidopa levodopa, maybe it helps for 2.5 hours, but then it wears off and they can't move. And they can't just take extra carbidopa levodopa because maybe they have side effects. They're having hallucinations or something. And so the entacapone just extends the action of the levodopa a little bit. Okay, and so it helps for wearing off. That's its one indication. But that wearing off is a big problem. So we often will try entacapone in that setting. Okay, so you can't give entacapone by itself. It doesn't do anything. You have to give it with the carbidopa levodopa. Just like carbidopa by itself does nothing. All right, it only to prevent the nausea that's associated with levodopa. And so there is a single medication in one pill that combines carbidopa, levodopa, and entacapone. So sometimes that can be that combination can be quite beneficial. Now, we don't use this very often, but in an advanced case of Parkinson's, where you're just trying to pull out all the stops to help the patient, you can advise patients to take the carbidopa, levodopa, the trade name there is Cinemet, but carbidopa, levodopa, to take 1 hour before or 2 hours after a meal so that the protein doesn't compete so much with the absorption of the medication. Now, if we have a patient just with severe Parkinson's, we're looking for other options. More than 10 years ago, 15 years ago, they were doing pallidotomies where you would actually put a lesion in the brain. Okay, and I'll show you with the brain circuitry here where you could put a lesion. But now, deep brain stimulation has definitely replaced pallidotomies. And in deep brain stimulation here, a probe is put into one of two areas in the brain, and we can see here they're looking at some electrical signals here because these areas of the brain have very unique neuronal discharge patterns. So you can tell exactly when your probe gets into the right area. And so the two areas that are used for deep brain stimulation are either the subthalamic nucleus or the internal segment of the globus pallidus. And so it turns out if you put a probe in the subthalamic nucleus and you stimulate that area, it ends up having the effect of shutting this down a little bit, which is a good thing in Parkinson's because now we have less glutamate being produced. And so years ago it was known that patients that had a stroke in the subthalamic nucleus could have an improvement in their Parkinson's disease. So that's, again, what's happening with deep brain stimulation. You can do the same thing here in the internal segment of the globus pallidus. You stimulate this area, which shuts it down a little bit so it doesn't produce as much GABA. And again, that's going to have a beneficial effect. You'll get more glutamate going back to the motor cortex. So, as I understand it, deep brain stimulation, if you're on the West Coast, they more likely do the internal segment of the globus pallidus. If you're on the East Coast, they more likely do the subthalamic nucleus. And I think things are being worked out in terms of which may be more effective. You don't need to know about that. But the real advantage of deep brain stimulation over a pallidotomy, where you're just putting a lesion in one of those locations, is that it can be adjusted. Okay, so the patient has the probe that is placed and has a wire that goes down the neck. They have a pacemaker-like device here. And then when they see their neurologist, the neurologist can make adjustments. So maybe things haven't worked out as well the last few months. Well, let's try making some changes with the electrical stimulation. This is a very complex area of neurology. To understand how to make these adjustments really requires a lot of training. So these are just not neurologists that do this, but neurologists who have specialized in movement disorders and really understand how to make those adjustments. So to be a candidate for deep brain stimulation, you need to have had a good response to carbidopa, levodopa. So these are patients that have responded well, but as the years have progressed, they need other options. Now let's move on and talk about different causes of Parkinsonism. All right, and so we have progressive supranuclear palsy and multi-system atrophy. And I would love to tell you about cortical basal ganglionic degeneration. It's very interesting, but it's, I think, rare enough that you're not going to get a board question on that. So again, these patients look superficially like they might have Parkinson's disease, but they have unique findings, as we will see. So PSP, or progressive supranuclear palsy, these patients have early falling. That is frequently the first symptom. So I mentioned that's a red flag symptom that suggests an alternative diagnosis. So if we have that story of early falling, of course we want to do a careful neurologic examination. And these patients frequently have an eye movement problem, especially with vertical eye movements. And so remember, a saccadic eye movement is a quick eye movement. And if we ask these patients to look up, maybe up at your finger, and then maybe down, maybe you're holding a pen kind of at their waist level, and we have them go up, down, up, down. Early on, these patients lose especially the quick downward saccadic eye movements. Now, as time progresses, all eye movements are affected, but early on it's more of a vertical eye movement abnormality. So I didn't mention that with Parkinson's disease. That's a unique exam finding of PSP. These patients also tend to develop a dementia, which can be rather significant. We call it a subcortical dementia. When you hear that term, and again we'll spend more time on this in the dementia lecture, these are patients who kind of look like a depressed patient. They're withdrawn. They're not talking much. Sort of a depressed dementia. That would be in contrast to Alzheimer's disease, where they're very outgoing and talkative. So there's a little different feature there. Patients with PSP often are felt to have Parkinson's disease early, but they don't respond to medications. Remember, that's another red flag symptom, not responding to medications. And the cortical bulbar tract here, as it travels through the midbrain, is affected in PSP, and so these patients often have pseudobulbar palsy. Okay, so those are kind of the unique clinical features of PSP. So this usually starts around age 63. Average survival is 7 years. And the protein in PSP is tau, which accumulates in the cytoplasm of both neurons and glial cells. And so PSP is one of several conditions that we will call a tauopathy. Okay, so again, Parkinson's disease is a synucleinopathy. If we have a case of atypical Parkinsonism, it doesn't really look like Parkinson's disease. Usually we're going to get an MRI scan of the brain in those patients. And in PSP, we have significant atrophy of the midbrain. And this creates what some have described as what appears like a hummingbird here. So it's the hummingbird sign, and that's just from a loss of bulk here of the midbrain. So remember that with regards to eye movements, the pons is mainly important for horizontal eye movements, the midbrain for vertical eye movements. And so that's why in PSP we have midbrain atrophy and vertical eye movements are significantly impaired. All right, so the other one here in our differential is multi-system atrophy. This tends to have a younger age of onset. Again, I'm not going to ask you the specific age, but 54 would be kind of the average age of onset there, certainly younger than Parkinson's disease. Now, multisystem atrophy, there used to be sort of three conditions that are now all lumped together as multisystem atrophy. And the only reason I mention that is one of those three is still used, I understand, by Step 1 boards, and that is known as Shy-Drager syndrome. So we really should just be using the term multisystem atrophy. And so of patients with multisystem atrophy, about 80% are patients who look Parkinsonian, but they don't respond to medications. And about 20% have ataxia in Parkinsonism. So the older term here, olivopontocerebellar degeneration, are patients with Parkinsonism and ataxia. Remember, I mentioned that as one of the red flag symptoms. If you find ataxia on exam of your patient who looks Parkinsonian, that's probably multisystem atrophy. Okay, so like PSP, these patients have early falling, red flag symptom. They tend to progress fairly rapidly. They're not responding to medications. And make sure you don't miss the third bullet there. MSA patients have profound autonomic instability early on. Okay, so they're passing out. They're getting very dizzy and lightheaded. Sometimes just going from lying down to sitting, they may pass out. So profound early autonomic instability in the context of other Parkinsonian features, your patient has multisystem atrophy. And so the older term Shy-Drager was the kind of the subtype that had profound autonomic dysfunction. Now, someone with Parkinson's disease that's had it for a number of years may have some autonomic instability, and that can be partly a side effect of medications. But I found that multisystem atrophy or Shy-Drager is often misused in that situation. So every Parkinson's patient that gets dizzy and lightheaded does not have MSA. But if it's a very early, profound feature from the beginning, that's when we think more seriously about multisystem atrophy. There's a lot of overlap with PSP. These patients also have pseudobulbar palsy. Okay, and remember, this is a synucleinopathy, just like Parkinson's disease. And so these patients also have REM sleep behavior disorder. It's even more common in MSA than it is in Parkinson's disease. So again, ask about sleep, ask the spouse about sleep. If we do an MRI scan in multisystem atrophy, we can sometimes see some signal changes here in the basal ganglia. Doesn't show up that well here. And in the area of the pons and the cerebellum connections, we can have what's called the hot-crossed bun sign right here. Okay? And so if you don't know what hot-crossed buns are, there they are. All right? So we can see some sometimes helpful findings on an MRI scan in PSP and multisystem atrophy. All right, so we have in this lecture learned about two synucleinopathies, Parkinson's disease and multisystem atrophy. In our dementia lecture, we will cover a third synucleinopathy, which is dementia with Lewy bodies. Okay, and in the tauopathies, we will come to several other tauopathies, but for now, progressive supranuclear palsy is a tauopathy. Now, causes of secondary Parkinsonism would include vascular. So these are patients that have had a lot of subcortical strokes that involve the basal ganglia and basal ganglia circuitry. This tends to produce a lot of symptoms in the legs, a so-called lower body Parkinsonism. So they come in with a shuffled gait and falling. And if it's mainly below the waist, then we consider, that the patient may have had multiple subcortical strokes. But remember also PSP and multisystem atrophy has early falling. So it's different than your typical Parkinson's disease presenting with tremor and the falling is much later. So an MRI scan of the brain can reveal usually multiple subcortical strokes. Normal pressure hydrocephalus is a condition we'll talk about in the dementia lecture. They can have some Parkinsonian features, but we'll talk about that later. Now, the next category is very important because this is quite common that patients are given medications that block dopamine. So the two most common categories here would be the neuroleptics or the antipsychotics and the antiemetics. And so metoclopramide and prochlorperazine or Reglan or Compazine are frequently given for nausea or for other GI dysfunction. And so the problem is when these medications are just left on board for months or years, they help the GI tract and they prevent nausea by blocking dopamine. But if you do that for too long, then patients can develop symptoms of Parkinson's disease. So again, we use the term Parkinsonism. And so often the story that I see is someone comes into the hospital, maybe they have a surgery, they're nauseated, they're put on metoclopramide, they're sent home, and the medication just keeps getting renewed. And then I'll get a referral from someone suggesting that maybe this patient has Parkinson's disease. And well, no, we're put on that medication that blocks dopamine. And so the sort of the interesting kind of sad thing here is that even when you stop the medication, it usually takes months for the effects to wear off. So it's not a quick thing. Now, very important, if you have a patient with Parkinson's disease that is nauseated, don't give them metoclopramide or prochlorperazine. You need to give them something for nausea that doesn't block dopamine. All right, now in the antipsychotic or neuroleptic family, I'm going to let psychiatry tell you about all the different medications there that block dopamine. I'll just list the most classic example, which is haloperidol or Haldol. Okay, so again, that's a common side effect of using dopamine blocking medication. Now, patients that are on dopamine blockers can develop other symptoms other than Parkinsonism. So oftentimes they'll have what's called akathisia, and this is just a restlessness where patients can't sit still. They keep crossing their legs, fidgeting, they need to get up and walk around. They can also develop what's called an acute dystonic reaction, oftentimes after taking the medication, where they may have, their neck will twist suddenly into an abnormal position, or their eyes may get fixed looking straight up at the ceiling. So these are quite dramatic episodes related to taking the medication. We'll often see that in the hospital, maybe when the patient is put on a dopamine blocker for the first time. And tardive dyskinesia we will talk about in the next lecture, which is an involuntary facial movement typically that occurs when taking dopamine blocking medications. Now, what if a patient with Parkinson's maybe is having dementia and hallucinations, and they really need an antipsychotic to help them control those symptoms? You don't want to give a dopamine blocker, and so a couple of good options, well, really only one great option. Quetiapine is the one used most often by neurologists. So really helpful to know because this comes up all the time. So it's an atypical neuroleptic that doesn't have much effect on dopaminergic pathways. So this would be something that you could give your patient with Parkinson's, maybe to control some agitation or hallucinations related to dementia, but it's not going to make their Parkinson's worse. Clozapine is another option, but we don't use it that much because it can cause a very severe neutropenia, and you need to do very frequent blood testing to monitor that, which is kind of a pain. All right, so the next one here is MPTP, methylphenyl tetrahydropyridine. Not very common, but interestingly, there's an exam you have to take in order to qualify to take step 2. And of all the neuro questions, and there weren't that many on that exam, this was one of them. So I don't know why this was felt to be important enough to cover. But this occurs when individuals are trying to home manufacture, make a synthetic opioid, like a morphine. And so they're trying to make MPPP, okay, but instead it ends up getting converted to MPTP. And MPTP destroys the pars compacta of the substantia nigra. And so patients look a lot like they have Parkinson's disease, and interestingly, they respond to carbidopa-levodopa, which is Sinemet, and so they respond to treatment. So I've seen a few patients with this, and so the story usually comes on fairly abruptly after taking, what they hoped was an opioid medication that they'd manufactured. All right, so I think we'll stop there. Those are the hypokinetic movement disorders, and we'll pick up next time with the hyperkinetic family.